Thank you so much. I'm just going to talk on ocular trauma surface, that is mainly burns, and we all know acid is worst, but acid is it I can tolerate little bit except the hydrochloric acid, but alkalis are the curse for the eye. We all know that, and it can burn up to posterior segment. Also, there are lots of classification like Haggis, Roper Hall, and newer classification which includes the conjunctival burns also. When we are dealing with the chemical burns, we have to deal with immediate, acute, early reparative, late reparative, and sequelae. So in acute stage chemical burn, in picture we can see conjunctiva is lots of inflammation, copious discharge, and cornea also appellation stroma is there. So in this case, we have to have early emergency response with ophthalmic examination, proper examination, and proper sit or wash is utmost important. Sometimes we may have to take the support of Morgan ring. Swipe up the fornixes, that is the utmost thing, and pH balance is the important thing. Examine properly for necrosis of the limbal cells. So immediate goal over here is promote the epithelial healing, reduce pain, decrease inflammation, and prevent scarring. So whenever there is simple grade 1 injury, simply antibiotics, topical steroid, and topical cycloplegic works, but you need to call the patient each and other day. When there is grade 2 to 4, we have to, sometime we may have to take support of tetracycline, fluoroquinolone, and high dose of vitamin C along with soothing drops. And again, topical steroids, sometime we may have to give progesterone steroid also. So after doing long list of management, if we done, and even in this baby, after 1 month the inflammation doesn't subside, double evert the lead and look for the rest of the particle which is hidden under the superior fornix, which we need to remove. So whenever there is a burn, there are 5 stages. Surgery with the debridement. Here the goal is restoring the corneal clarity, normalize the ocular surface, and prevent glaucoma. So in this baby, after 3 days, 6 days of chemical burn, all the inflammation subside. We did the slat technique in this patient, so which is a very well known technique. We put the amniotic membrane, we take the limbal cell transplant from the other eye, we just distribute and we just pour on the amniotic membrane, and then we can again put the glue on that. This slat technique is very well known to correct for the chemical burn. So this is a 7th day post-op, and later on after 3 months gets the clarity of vision, which is published in IGO. So this is another few cases of the slat technique. But whenever there is a chemical burns in the conjunctiva, look for the diplopia, maybe simply because due to symblepharon. So symblepharectomy, excision, along with the sometime AMG is at most important. So you have to release complete scar of the tissue and then put the amniotic membrane graft. So after 3 months the revision gets clear. Especially in babies, we just put central hole in the cornea to prevent the amblyopia. So when we look for the lead socket, lacrimal area and orbit for the chemical injury, in lead we have to take sometimes support of skin specialist along with whenever there is a thermal burn associated with that. Let the lead edema subside, and then usually patient comes with ptosis, that is mainly because of symblepharon again. So in this patient also we did symblepharectomy along with the mucous membrane graft. So that works very well after this, and the cornea gets clear. Sometimes strabismus also comes because of symblepharon and because of deep alkali burns. So in this patient, muscle had lots of adhesion. We just wrapped it with non-absorbable material and then put the glue. Sometimes patient comes with entropion, simple entropion correction and trichiasis. So ciliary bed transfer we can do whenever there is a trichiasis. There are lot many newer techniques like anterior lamellar recession also nowadays people are doing for trichiasis. So here we just put the whole ciliary bed anteriorly, and that is less chances of recurrence of this trichiasis. So once you clear that, the cornea gets clear. Sometime mucous membrane graft along also when there is lots of keratinization as a sequelae of burn, we may have to put the mucous membrane graft. When there is a trichiasis of upper lid entropion, lengthen the posterior lamella with cantrotomy works. Trichiasis with upper lid entropion, reason for sulcus deformity here is posterior shortening, so volume augmentation also sometimes works. Sometimes patient comes for the enkyloblepharon, just release the enkyloblepharon and treat amblyopia. Cicatricial ectropion, that will mainly lead to lagophthalmos, so simple tarsorrhaphy can sometimes work, or sometimes we may have to do skin grafting along with the tarsorrhaphy. So whenever there is entropion, lengthen the posterior lamella, ectropion, remove the cicatrix and skin graft, trichiasis, ciliary bed transfer or anti-lamella recession, and whenever there is lid defect, correct accordingly. When we go into orbit, there can be orbital trauma which can lead to fornix, like shallow fornix, shelled fornix, obliterated fornix, wet contracted socket or dry contracted socket, and again we have options available are amniotic membrane after removal of the releasing the scar in this orbit. So in this patient also we have done mucous membrane graft after releasing the scar which was burnt by chemical burns, alkali. Mucous membrane graft, and then you can just properly fit the prosthesis. Fornix formation is utmost important in such kind of patient, and we may have to take support of again skin graft to fit the proper prosthesis. And again fornix reconstruction with AMG can be done, but don't forget to put fornix forming sutures and or symblepharon ring, or sometimes simple conformer if something is not everything is not available. In this baby we did volume augmentation with dermis fat graft along with canthotomy and mucous membrane graft, and then we can give little bit gratifying result. But this kind of patient is definitely needs experts and multiple team approach to treat. So I'll not just go into detail of the lacrimal area burn. We have devised newer technique and which is already published. But then again, whenever there is lacrimal area burn, thorough wash but no syringing, because you are just pushing the chemical again into the sac, so don't do this. Conjunctival DCR is the approach, probing with bicanalicular intubation and probing with modified pigtail, which is our own technique, can be done. And lacrimal sac we can just do intracath DCR, skin root or conjunctival root. So in conclusion, multidisciplinary approach at the same time, multiple surgeries and poor prognosis, and take care of the legal issues. Thanks to my patients, thanks to my teachers, and thank you for patient listening.
Thank you, Dr. Shah. It was a wonderful presentation, and these are difficult scenarios to handle, and many times you must be doing multiple surgeries for a single case.
Yes,
and
in our tribal area, the most important part is the father and mother send a baby to get the tuna packet. So I'm really grateful to now OTSI, because they have done some government licensing, and now they have banned tuna packet, not banned tuna packet, but they don't give to children, and they have promised to double wrap the tuna packet. So at least that much action has been
and for that I would like to congratulate Dr. Mehul Shah for this. He has done a lot of efforts, and I mean the whole team has done it, but he has led from the front, and that is wonderful.